Good evening. Welcome to 42BR's annual lecture. For those that you don't know me, I'm Rebecca Thomas. I'm the head of the employment team. I'm really pleased to introduce our panel for this evening, who are going to talk about the next hot topic, menopause. We've got two of our excellent team members, Laura and Susan, and we are also joined this evening by Dr. Laura Wood, who is a GP and menopause specialist. So this evening she's going to start by giving us a short presentation, and then we're going to have a more general panel discussion about some of the legal implications of menopause. And I'm hoping you're all going to join in with some insightful observations and questions. In the interest of saving the planet, we do have some handouts. We've printed out a limited number. Feel free to take one, but we will be sending an electronic version to everybody tomorrow, so don't feel you need to take one away if you don't want to. After the presentation, there will be drinks and food next door, so we hope you'll join us there. And over to you.
Thank you very much. Thank you very much for having me speak this evening. I'm Laura Wood. So as Rebecca was already introduced, I'm a doctor primarily, and I'm also a transformative menopause coach, and spend most of my life talking about menopause. So I combine my sort of medical expertise and my coaching to deliver a sort of a holistic approach to a lot of women going through menopause, so they can not only improve their symptoms, but also optimize their future health, which is quite a lot of the emphasis I'm going to place on tonight's talk. So the first thing are some definitions. These words all get bandied around a lot, and there's a lot of confusion sometimes. Menopause gets used as an all-encompassing term, but the menopause, the definition is it's the day from your last menstrual period, and it's normally around the age of 51. It's fairly irrelevant, to be honest, in terms of it's nice to know when it was, but we don't know when that date is until about a year after it's passed. So it's a retrospective diagnosis. And the most important bit of all of this for most women is the perimenopause, which is the hormonal fluctuations that lead up to this exciting day. What a lot of people don't realise is these symptoms can start super early compared to your average age of 51. So they can start up to 15 years before. So that means a lot of people in their mid-30s are already starting to experience hormonal fluctuations, and they often don't realise that this is anything to do with perimenopause. And the symptoms can last for many years, and when asked how long, my favourite answer is how long is a piece of string. It can be up to sort of, yeah, as I said, 12, 15 years for some women, and some women will still tell me in their 70s they're getting horrendous hot flushes. So it doesn't necessarily have a strict end date. And there's a really wide array of symptoms. But why does it matter? So the symptoms that people can experience, everyone sort of thinks about hot flushes and women's periods changing. They're often some of the later symptoms to come in. And we get difficulty sleeping. I don't know why some of these have gone into lowercase, sorry. Problems in memory and concentration, low mood, anxiety issues, reduced sex drive. People suffer with vaginal dryness. They can find sex uncomfortable, and they can get lots of urinary tract infections as a result of this. They may get joint aches and pains, back pain, shoulder pain, any kind of musculoskeletal pain, which they may not realise is anything to do with their hormones. Women lose their muscle mass, and then we've got the typical hot flushes, night sweats, and changes in their periods. And as I've sort of touched on, so many women just aren't aware that what they're experiencing could be anything to do with menopause. So our symptoms all mostly come about from a loss of estrogen, and these levels fluctuate in the years up to our last period, and then they decline quite rapidly after that. And that affects our brain, our hearts, our skin, and our bones. And I'm going to come on to explain the importance of all of those. And for years, many women have just probably heard the narrative that we just it's something natural. We just get on with it. We suffer it. We've probably seen our own mothers do that. And that's probably not the greatest idea. So, sorry, some of my slides haven't quite come up. So, with the decreased estrogen, we're getting issues with stress, anxiety, low mood. That feeds into the sleep disturbance that's also occurring because of our loss of hormones. We get hot flushes, night sweats, and as you can see, there's some arrows here that haven't quite come up very well. They all feed into each other. So when we're sleeping really badly because we're getting horrendous hot flushes, we're then waking up exhausted, more stressed, more anxious. That's feeding into us not sleeping as well again the next night, and it all ties in. So it's a bit of a vicious cycle. 51% of the population will experience menopause, and 100% of the population will know someone that's experienced menopause. And there's still a huge stigma associated with it. It's getting better. There have been a lot of wonderful coverage of menopause over the last few years, especially, and people are talking about it more, but it's still very stigmatized, and a lot of women are embarrassed to even talk about it. And it's important because women of menopausal age are the fastest growing group in the workplace. And 3 in 5 women are negatively affected at work. And there was a survey that BEPA undertook that found that 900,000 women left their job due to perimenopausal symptoms. So it's quite a problem in the workplace. 45% of women say that their menopause symptoms had a negative impact on their work. And 47% who've needed to take time off work due to menopausal or perimenopausal symptoms, say they wouldn't tell their employer the reason. And I think there's a lot of reasons for that, but that stigma is a huge part of it. So we need to offer a huge amount of support so we're not seeing such shocking statistics. Menopause is an inevitable and natural part of growing older. Women feeling compelled to give up work at the peak of their career is neither inevitable nor normal. So if you remember my slide with hearts and bones and skin and brains on there, if we think about all the symptoms we know about of perimenopause and how disruptive they can be, which many women are pretty aware of, these are things people may not be aware of. So as our estrogen levels decline during perimenopause and after menopause, that increase our women's risk of high blood pressure, high cholesterol, and ultimately increased risk of heart attacks and strokes. So when we look at heart attacks and strokes, they're the 2 leading causes of death in women in the UK. Breast cancer and lung cancer come after that. A lot of women get very worried about breast cancer. There's a lot of adverse reporting about the risk of HRT and breast cancer, and actually we're 30 times more likely to die of a heart attack or stroke than we are breast cancer, so we need to be worried about our hearts. Oh yeah, that's what I've already, so we've got a rise in cholesterol, we get an altered fat distribution, which is why so many women struggle with weight after menopause. Blood pressure goes up, our inflammatory markers go up, and the lining of our blood vessels, the endothelium, becomes more sticky and causes problems with build-up and ultimately narrowing of our arteries, which all puts together for an increased risk of heart disease. We know that estrogen is protective against heart disease, and that's why up to the point of menopause, women have a lower risk of heart disease than men. Unfortunately, after menopause, we're in the same group as men. We have exactly the same risks. We've lost that protective effect. And we now know that there's a significant reduction in the risk of heart disease if we start HRT within 10 years of menopause. So this is if the red bar is in women over the age of 60 and green, the under 60s, but we're seeing a huge risk reduction with HRT. And this is something a lot of women and men don't know about. So we also need to know about our bones. So osteoporosis affects 1 in 3 women, and 1 in 2 women over the age of 50 are going to have a fracture. And the wrist, hip and spine fractures are the most common. And yes, it's not very pleasant to break your wrist, but it's probably not going to have a huge impact. But we start breaking our spines, we start breaking our hips. Those lead to huge problems in frailty and increased risk of death. So 10% of people with hip fracture will die within a month of that fracture, and 33%, so a third, will die within a year. Those stats used to be loads worse. And when I was a junior doctor a long time ago, we'd say 95% of people were dead within a year after a hip fracture. So we have made some improvements. But
because a lot of very old women get hip fractures.
Yeah, it's a marker of frailty. So if you are older, if you are frail enough to be falling over and, you know, falling that way, you're more likely, you know, that's how you're going to break a hip. But so, yeah, that mortality is much more in older women, but we want to be not getting to the point that our bones are that bad that if we do fall over in our 80s that we're going to break a big bone. And sadly, the number of fractures is going up. So in 2006, there were 70,000 a year in this country, and in 2020, there were more than 100,000. We're all living longer. And my main ethos is it's not just about getting old, it's about having good, healthy years in old age. And there's no point being here, you know, and having a really miserable existence. We want to be enjoying it and not needing help getting to the toilet. I'll come back to toilets. So, and now the slightly more icky for some people part of this, I'm going to talk about something called urogenital atrophy. But we all know after menopause, our skin changes, we get more wrinkly. We've lost a lot of elasticity and collagen, but unfortunately, skin in delicate areas in the vagina also gets thinner and gets more friable. So we get low estrogen causes this chronic condition. It affects the vagina, the vulva, the area around that, and also the bladder. And so many women think this is just a normal part of aging. We accept that maybe we're going to be a bit incontinent. We're accepting that things don't feel great down there. We feel a bit dry. And so many people don't want to talk about it because they're really embarrassed to talk about their vaginas. So therefore, it is underdiagnosed and vastly undertreated. And it's what I call the silent epidemic. But why does this matter? Because we could just put up with this, is what so many women think, and women tell me they should do. But this is something that's going to affect nearly every woman. And as we are an ageing population, we're going to have more and more women affected by this. And this low estrogen causes thinning of all the tissues in the areas I've spoken about. And that leads to an increased risk of urinary tract infections, so bladder infections. Now, probably most women have had a urinary tract infection in their life, most common in their sort of early 20s, and it's unpleasant. You're rushing to the loo all the time, it hurts, it's not very nice, you have some antibiotics, it gets better. Unfortunately, when we become old, those symptoms aren't the typical symptoms, and sometimes the first symptoms women can be aware of or not aware of is they become very confused and they fall over. It's a huge source of hospital admission and sadly a huge, very common cause of death. So it's super important because we've just talked about our bones being weak, and if we fall over because we're confused with a urinary tract infection, we've also got a high chance of breaking our hip. Let's say, so if left untreated, they can lead to severe infection, sepsis, and in most serious case, death. And the majority of hospital admissions for urinary tract infections are in adults over 65. And what many people don't understand is that even if they're on hormone replacement therapy, which is addressing a lot of their other symptoms, unless they're using specific estrogen applied locally to that area, to their vaginas, they can still have all these problems. And we know that using vaginal estrogen reduces our risk of urinary tract infection by 50%. So we could halve these hospital admissions by every woman using them. Why do people not seek treatment for their menopause symptoms? As we said at the beginning, a lot of people don't realise their symptoms are attributable to menopause. They'll often go to the doctor with lots of individual problems because they can't put the link together. They've got a frozen shoulder. They've got back pain. They've got horrendous anxiety, and those three are often not linked, as a good example. And sadly, you know, with a 10-minute GP appointment for most people, that's a struggle to a GP to make unless they've got a bit more time. There's often multiple doctor visits before the kind of pieces are put together. And sadly, a lot of women are wrongly diverted to mental health services for their very difficult, you know, anxiety or depression, and will get wrongly treated. There's a lot of women who are concerned about the safety of treatment. There was a huge study in the early 2000s, which was published, which is a Million Women study in the Women's Health Initiative, which the bottom line was breast cancer. HRT is really dangerous. Everyone's going to die of breast cancer. We should all stop now. To put it succinctly, and that led to mass terror. Doctors were terrified to prescribe HRT, and everyone came off it and very upset. And what has been even worse with that is it led to a massive halt in a lot of research for a good 15 years, and we're only now coming out the other side of that and putting together. And the study was hugely flawed. It was looking at much older women. It was looking at much older methods of using HRT, and so those results aren't, you know, applicable to the women, you know, who are taking HRT now. And then, yeah, lastly, women may be embarrassed to talk about intimate symptoms, and a lot of that is because then maybe not educated to feel that it's something that's okay to talk about, and they just feel they're on their own, so they will pretend it's not happening, and maybe just go with it's something I have to just deal with. So what can we do? So hormone replacement therapy, I could talk for hours about. It will deal with a lot of symptoms. It will help women hugely. There are some women that can't take HRT, and it isn't the answer to everything. It's not a magic pill that's going to cure everything. So it really needs to be done in conjunction with lifestyle changes. And so with that, I'm talking about optimizing diet, exercise, mental health, and we can treat low mood, certainly for people women who aren't able to take HRT, antidepressants and cognitive behavioural therapy, so specific type of therapy, is really helpful, but isn't going to change everything. It's not a case that having some therapy will get you over your menopause. And then you can seek help similar to that which I offer, which is, you know, personalised health coaching to help with symptoms, but actually make sure hugely that you're optimising your future health for a healthy old age and getting yourself into a healthy old lady body, not into a frail and unwell one. So in summary, menopause can have serious adverse effects on mental health and performance, causing many women to leave their jobs. It can impact heart health and bone health and urogenital health, and the bottom line is it really shouldn't be ignored. And if you want to know any more, my contact details, which I shall leave up. Thank you very much.
Thank you. We're going to now consider some of the legal questions that arise from menopause. So we're going to pose a series of questions to each other and and then invite discussions from yourselves and questions from yourselves. So my first question is menopause a protected characteristic, other Laura?
So not on its own, but obviously there are a number of protected characteristics that could be applied. So it might be that if you've got lots of what sound like really awful symptoms and for 15 years, then you may of course be disabled. And if you're disabled by your menopause symptoms, then of course there's a range of claims that you might be able to bring, or things that you might be able to ask your employer to do to help you so you don't have to leave your job, so reasonable adjustments. If people are trying to performance manage you, you could perhaps say that that's discrimination arising from your disability. You might say that the person who keeps fanning you and opening the window is directly discriminating against you or harassing you. So there's a number of different
So we have the definition under Section 6 of the Equality Act. So it's a physical or mental impairment which causes a substantial and long-term adverse effect on your ability to do everyday activities. So is that the definition that would apply to see whether in a particular case the employee who was going through either perimenopause or menopause, whether they would be disabled? What about other protected characteristics that I think you have a case there where in fact there was a finding for the claimant, but they didn't actually rely upon a menopause in the context of disability, but under gender.
Yes. So Mrs. Anderson worked as an office manager, and she worked in a company which was described in the judgment as one where there was a lot of use of swearing and industrial language was commonplace. We love an industrial language test. Absolutely. And she worked closely with two directors, James and Jim, who were father and son. And in August 2021, the claimant informed the respondent that she had the menopause and was experiencing symptoms, and it badly affected her, and she had to undergo some blood tests to check her hormone levels, and she then had to have a scan to investigate her menopausal bleeding, and the respondent was quite sympathetic, and they paid for her to have a private medical assessment in relation to those menopausal symptoms. And she then began to suffer loss of concentration, brain fog and anxiety, and was prescribed antidepressant. So far so good. Then in December 2022, the claimant had 1 day working from home because she was snowed in, and 1 day working from home the following day due to menopausal heavy bleeding and associated pain. And on her return to the office, Jim Clark, during an altercation about the time she spent away from the actual office, said, and it's a Scottish case, and I do think
I think you should definitely do the accent.
Go on.
my Scottish accent is not good, but I think you should imagine it in a Scottish accent. He said, I quote, menopause, a biddy fucking gets it. Just get on with it. That's your excuse for everything. The claimant was a bit upset. She raised a grievance. She left the office. She raised a grievance and she was signed off sick. And so the respondent removed her computer access and she resigned. Funnily enough, the Employment Tribunal found the comment by Jim was harassment related to sex, but she was entitled to consider that it had breached her mutual trust and confidence, and that the last straw was the removal of her computer access, entitling her to resign and claim constructive unfair dismissal. So she ended up with just over £18,000 in compensatory award for the unfair dismissal, £10,000 injury to feelings for the comment, and some unpaid wages of about £8,000. So she ended up with a very significant sum of money. She didn't claim disability discrimination in relation to the menopause, and she relied entirely upon the comments about menopause being inherent related to sex, and succeeded on that basis.
So we do have a couple of cases where menopause has been relied upon as a disability, and one of them, the important one, called Rooney and Leicester City Council, which is an employment appeal tribunal judgment given by His Honour Judge Taylor. So this was a case where, at the first instance, the claimant was a childcare social worker. She resigned claiming constructive dismissal, disability, as well as sex discrimination. Her symptoms had been insomnia, fatigue, low mood, irritability, anxiety, heart palpitations, memory loss, confusion, concentration problems, low self-esteem, confidence problems, headaches and migraines. She had all sorts of difficulties, including urinary problems. It led her to forget to attend events and meetings, losing her personal possessions, forgetting to put the handbrake on her car, forgetting to lock her car, leaving her cooker or iron on, leaving the house without locking doors and windows. So really, really significant symptoms and prolonged periods in bed due to her fatigue, dizziness, incontinence and her joint pain. So the detriment she was complaining of, she got a written warning for sickness absence, and she had a male manager saying in response to her complaint that she was getting hot flushes, he said, "Well, I get hot in the office too." rather sort of dismissing her symptoms. The tribunal of its own motion actually fixed a strikeout deposit order hearing for the hearing of her claims, and they essentially struck out her menopause claim. The judge found that her condition did not amount to a disability. The employment tribunal judge had noted that the claimant was able to provide care for others and that she could carry out day-to-day activities in this respect. And so the tribunal had dismissed her disability discrimination claim and struck out her sex discrimination claim. She appealed, unsurprisingly. His Honour Judge Taylor in the EAT was unimpressed by the judge's analysis, and he was referred and found helpful the Equality Act guidance on matters to be taken into account when determining questions relating to disability. And it's quite handy if you read the judgment, because he's actually put in bold certain sentences in that Equality Act guidance. He stresses that there may be adverse effects which are both physical and mental, and you don't have to necessarily say it's either a physical condition or a mental condition. You can have cumulative substantial adverse effect. It doesn't need to be just broken down, each particular symptom you need to prove the substantial adverse effect. It can be cumulatively if they cause a substantial adverse effect. You should also take account of things where a person avoids doing things that may cause, for instance, pain, fatigue, or substantial social embarrassment, or you avoid them because of a loss of energy or motivation. And even if an impairment does not directly prevent somebody from carrying out a normal day-to-day activity, it can still have a substantial adverse effect on how the person carries out those activities, for instance, because of pain or fatigue. So Judge Taylor said really had considerable doubts about how relevant it was that the claimant was still able to provide care for others. He emphasised many people, including those with disabilities, have caring responsibilities. These effects have been long-term, as they'd started in August 2017. She resigned over a year later in October 2018. He criticised the Employment Tribunal for not explaining or not reasoning why it was that effects or impacts such as forgetting to attend events and meetings, losing your possessions, forgetting to put the handbrake on the car, forgetting to lock your car, having to spend long periods in bed. The tribunal had just really dismissed all of those without giving any reasons or indications why this was not a substantial adverse effect on your ability to do everyday activities. So he concluded that the tribunal had fallen into error in determining what she could do as opposed to what she couldn't do, and that was contrary to the guidance given in a case called Ahmed and Metroline Travel. So essentially, that he found that the tribunal had erred in finding that the claimant was not a disabled person. It was remitted, but to a differently constituted tribunal to reconsider that matter. And there's another case called Linskin Direct Line Insurance cases. That's the first instance tribunal case. That's happened since the EAT case. And this is called Linskin Direct Line Insurance Service. Claimant was a telesales consultant for Direct Line, and she brought a Section 15 complaint. So Section 15, of course, is where you're relying on something that arises from a disability. And importantly, she had been a good employee from 2016. She'd had good or very good performance ratings. And then 3 years later, she'd started suffering menopause symptoms of low mood anxiety, mood swings, poor self-esteem, poor memory, concentration. She was prescribed antidepressants, but essentially started her performance and her role really started dipping. So there's something arising from the menopause symptoms she was having was essentially her, there's something arising was her symptoms, her menopausal symptoms, which were arising from the fact she was in menopause. These were symptoms of brain fog, intense anxiety, her inability to retain information, emotional instability. And the detriment that she was subjected to was that she was getting bad performance ratings, and she was actually put through a disciplinary process, was given warnings, and also because she had a poor appraisal, she was marked as need for improvement, and her pay was linked to getting a satisfactory rating. So she was also financially suffering as well as having that poor rating, which is not very encouraging. Basically the tribunal found for the claimant. They said that the respondent could have given her the benefit of the doubt. She'd been a good performer previously, and the tribunal considered the Section 15 justification defence, but they weren't convinced by it. And interestingly, what they pointed out was the deficiencies in the way that the employer was running their justification case. The tribunal said they did not hear from the respondent about the examples of policy or decision making for disabled people generally, what was done for those ill or absent because of treatment or appointments, whose performance was affected by disability during a performance year. They didn't hear how that had been applied or applied to the claimant. They didn't hear of the consequences for overall profit of customer service of rating the claimant. They didn't hear about appropriate explanations or measures in place, or any way in which less discriminatory steps, why those less discriminatory steps could not be taken or could not be appropriate. So it's an interesting example of really, although it's only first instance, Section 15 claims, I suspect, will be quite commonplace or frequent in menopause cases. But so justification is going to be quite a key issue, but really the onus is going to be very much on the employer to produce those explanations and provide a good justification defence. And this claimant got £23,000 for injury to feeling, as well as £2,500 aggravated damages award. So substantial.
So, Susan, what should responsible employers do as regards menopause now that we've heard what the irresponsible ones should not do?
I think the first thing really is policies, either to create a policy or to review policies if you don't have one. And we've got some handouts here. So we've got guidance from ACAS, we've got guidance from the British Medical Association, and also from the Equality and Human Rights Commission, which sets out some steps that you should be really looking at. We've also got, I think, an example from the BMA, the British Medical Association, of the model template policy, or of the considerations that you should be looking at to include in your policy. So the sorts of things that you might include in a policy, what you do about attendance issues, performance issues that may be related to menopause, perhaps OH advice. And really, but what you need is an OH advisor who is knowledgeable and experienced in menopause issues.
Maybe just say there are so many medical professionals, gynecologists included, who don't realise it's menopause.
Oh, right.
So yeah, when you say in terms of OH, making sure they are,
actually qualified.
Up to.
Can I ask a stupid question, Laura? How? I mean, is it as simple as checking hormone levels?
No.
To know if it is menopause related?
It's not, because, and actually hormone levels, they give a snapshot of what's happening on one day. So they don't tell us anything really. So I almost never use hormone levels unless you think somebody's going through a very early menopause and you're really questioning what's going on. Because if I tested somebody's hormones one day, the next day they might be totally different. So even if they're abnormal, the next day they might be normal, they might be normal for 3 months. Might see somebody in their 20s who's got possible sort of raised FSH, which is one of the things you look at, and they're trying to conceive and they're terrified and it's just a blip. So we don't use, so there's not a simple thing you do go, yes, definitely is. And it was interesting, you know, all of those cases, everyone thinks they've got dementia, pretty much. And it's terrifying. So people, when they go to the doctor, they're so frightened. It's like they sort of lead, you know, the doctor can always lead down a path of something else.
So I think, and other things that policies might, menopause policy might look at is reviewing the physical environment. So measures like for hot flushes, measures like fans, ventilation, maybe a quiet space for somebody who is feeling very anxious to go and have chat. Perhaps a mentor who is known in the workplace as somebody you can go to with menopause issues, as a menopause champion. All sorts of things like that. Maybe training to managers, particularly if there are disciplinary or attendance or performance issues, because the difficulty with menopause is that it can range over so many different aspects of employment that people may not even necessarily initially make that connection.
So it affects literally every part of the body. We've got estrogen receptors throughout our entire body, so almost anything could be attributable to it. But in terms of how it affects people at work, it can be huge.
And you can see the pitfalls when employers are just blithely imposing disciplinary or performance or attendance sanctions without taking into account something like that.
But it'd be a good idea as well, perhaps not to take into account any menopause related sickness. If somebody actively says this is menopause related sickness, like in Anderson, she had a day off for menopausal heavy bleeding, not to put that into the formula that works out whether they should be attendance managed, because it might be a bit like pregnancy, but that would obviously be discriminatory towards women.
And the more people talk about menopause and are aware of it, and it's less of a stigma, because the statistics sort of 45 or 47% of women who take time off work for menopausal symptoms won't tell their employer that's why. So women have got to actually feel comfortable in the first place to say, this is it, you know, as opposed to, oh no, everything's fine, I've just got a cold today, you know, or whatever it is. So we need that conversation.
That leads me to my next question. So I asked Laura, should an employer approach a female employee who appears to be struggling at work and say, could you be suffering menopausal symptoms?
No, please don't. I think you know, preparing for this talk, one of the things that we talked about is it's actually really difficult because, as Laura said, the person who might be suffering the menopausal symptoms might not put that together in their head and might not know that they are. The employer might be the person who notices more than anybody else that they're perhaps struggling in the workplace and not perhaps performing as they were before, and something is going on. But it's certainly not a good idea from a discrimination point of view to say to somebody, you're a woman of a certain age, might you be a bit menopausal?
So you seem a bit sweaty.
It's a bit like, is it that time of the month?
Yeah, absolutely. Yeah. It could be quite offensive.
What's the answer? What do I do?
We thought the answer was to perhaps have a more general well-being conversation with somebody who appears to be struggling, and to just sit down and say, you know, you perhaps appear not to be quite yourself, or you appear to be struggling a little bit. Is there anything we ought to know? Offer to send them to occupational health or to a medical appointment if you think that perhaps something is going on that they may not realise. And then I think you've got to sit back and hope.
And if you've got the culture in the workplace where you've got a menopause policy, these things are the culture sort of changed so that it's sort of, you know, can be openly discussed, and you've got maybe a known person who may be your equality person in your workplace who is trained in menopause issues, and everybody knows that they are the person to go to, then you would hope that instead of waiting for the point where the employer is having to say there's a performance issue or something, that employee will have gone to that equality mentor or champion in order to raise an issue before it becomes an issue that the employer is having to bring up, and therefore is by its essence quite confrontational. So
we also are partly hoping that as time goes on, it won't be so not obvious to people, that people will start thinking more about menopause, and, you know, with things like Davina McCall and the TV programme.
It's brilliant.
Massive sea change.
Well, actually, maybe I've had some of those symptoms, so maybe I should go to the doctor, and that you know,
And
more
it's become a
women
bit of a saying now, or it's a Davina thing. My friend said she rang at the GP to ask for an appointment, said, it's a Davina thing. And I thought, right, and everyone, almost that seemed less, difficult to say potentially than, so Davina's, I mean, done a brilliant job in terms of awareness. And I think in terms of the menopause champion in the workplace, I think you also need to make sure that somebody who's genuinely interested. I've had quite a few accounts of people, oh, we want a menopause champion, and somebody reluctantly puts their hand up, and actually they did a day's training and they're actually not interested at all. And it's you want to make sure how you make that, but make sure there is somebody with actual interest in it, rather than it's a tick box exercise that they provided a menopause champion.
Which leads us on to, what about things like indirect discrimination?
Yeah, so I was quite struck. There was an article in The Guardian that talked about this very interesting 10-year study of 2 million women in England, which showed that there's actually massive differences in terms of the ability to get HRT prescriptions, differences for women of different ethnicities and races, and also socio-economic people, the differences in their ability to get HRT. And I suspect that's made up of a combination of both the willingness or sort of coming forward, the women coming forward to go and ask for it, but maybe also in the doctor's treatment of those women. But essentially, this University of Oxford study found that between 2013 and 2023, almost 6 times as many white women were prescribed HRT compared with black women, and more than twice as many women in affluent areas, so richer women, were offered HRT than those living in socially deprived areas. And there's a big difference in ethnicity. So women of Chinese backgrounds, such as myself, are 82% less likely to get HRT than Caucasian women. Black African women are 79% less likely than Caucasian women to receive HRT. And there's similar as it were, disadvantage in terms of those women from Pakistani, Bangladeshi and Indian backgrounds. They're far less likely to be on HRT. And this trend is apparently worsening since 2016. So albeit this is about treatment rather than the fact of whether or not you're suffering from menopause symptoms, there is a potential, I suppose, for potential indirect discrimination claims as well arising from the menopause, in that if you're from a particular ethnic group that is known to be far, far less likely to be able to try and alleviate or mitigate the symptoms by getting HRT, which is still, I think, the first line of treatment, ideally, for women, then there may be an indirect discrimination claim arising from race, as well as your disability claim and your gender claim. So
And
that's
possibly
quite
age.
interesting.
That's the other one.
Yeah,
we probably
age,
haven't
of course, yeah.
mentioned, obviously.
Yes.
You could have an age discrimination.
Yeah. And interestingly, black women apparently have an increased rate of symptoms such as hot flushes compared with other racial or ethnic groups. So perhaps certain sorts of symptoms impact upon different racial profiles differently.
So that might help them get their HRT, because there are so many people that if for HRT, really a sort of license for the treatment of hot flushes is almost its main. And if if you're playing, doctors are like, oh, well, you can't have it, you're not having hot flushes, and people don't realise unless they have hot flushes that it's perimenopause or menopause. So in a way, once they present, they might be marginally better off. But I think a lot of this is also, there's a lot of stigma in these ethnic groups about menopause and education. They don't realise.
Yeah, absolutely.
Symptoms.
There's sort of potentially, I think we were discussing this, probably cultural, religious differences as well, in terms of the willingness of certain groups to go and discuss these issues with a doctor. But certainly Asian women have a higher risk of osteoporosis than other ethnic groups, and they're also far less likely to use HRT, which is interesting. So, yeah.
And they've got a higher incidence of heart disease.
Yeah.
Sorry.
So,
Just to be miserable.
yeah. So yeah, so those I think were the questions we were going to cover. But any questions to any of us about anything? Yeah, go.
I had a question about how you think constructive knowledge of disability would work in the context of menopause, because it's kind of unique as a medical condition. Well, I suppose that and death are the two things where, you know, like if a female employee stays with your business for long enough, there's a sort of 100% chance that they'll go through the menopause. So I suppose the question is, given that, you know, if as an employer you have, let's say, an employee aged 50 who has suddenly and inexplicably become very forgetful, would you be fixed with constructive knowledge? I mean,
That's a really interesting and tricky question. And I suppose I think it would depend upon a whole load of factors. I don't think it would be very case sensitive, and it would partly also depend upon whether or not the employee themselves had raised it, because they had no awareness themselves and weren't attributing their symptoms to menopause. I think it's going to be harder for them to then argue subsequently that actually the employer had knowledge, even though the employee themselves didn't have knowledge, because it's about what reasonably you can be fixed with in terms of knowledge. And if the
I
employee,
didn't know, but you should have done.
yeah, exactly. I think it's quite hard to argue that. But if they have been raising it and then the employer is just turning a blind eye and saying, no. But it's a really difficult question, especially as at this age, you have so many life stresses. You're the sandwich generation. You're looking after elderly parents, looking after children, and there's so many stresses with life that it's not obvious.
Well, and often you've hit that key point in your career.
At the same time, yeah.
You know, so it all coincides.
Yeah.
And there are so many women that don't put it together in terms of stress. They think it's all, you know, external stresses and don't look inside.
Yeah, but if the employee, I suppose, is saying that they think that, even if they're not saying it's menopause, but they're saying they are having problems with their concentration, I suppose what you would do is maybe send to OH, and then there's the OH advisor, I think, to really try and explore that and see if you could say, well, is it a hormone? It might be a hormonal problem or something. You know, do you want to see our OH advisor and get them to?
I have to say, I think you may have a little more faith in the average OH staff.
Yeah, you're right. It is very much dependent on the quality of the OH advisor and how much they're aware of those issues. Because I think you were saying that a lot of doctors have no idea.
I mean, I'm stunned by the number of other doctors who, and when I say gynecologist, that is even, you know, that's
extraordinary.
But when I trained as gynecologist before I became a GP, and my, you know, obs and gynae exams, I could tell you the amount I learned about menopause and knew about menopause, I could write on the back of a postage stamp in thick lead pencil. But, you know, that's horrendous. This is something that everyone's going to go through, and it's changing, but there are still a load of people that have no clue. So yeah, I think the OH thing is a good.
I mean, it does put employers in quite a difficult position, in the sense that, you know, you could have female members of staff with quite serious symptoms that, you know, going on for, you know, potentially a decade.
Absolutely.
And I think, following on from that, even if you get away with constructive knowledge, you've still got an arising from the real problem for employers.
There's also how it's handled as well. I have a friend who shall remain nameless. He works in a city institution who have a menopause policy and a menopause champion, and they're trying very hard. And she said to me, if my boss tells me to carry my personal hand fan around the office one more time, I'm going to put the hand fan somewhere the sun doesn't shine. And so I think they think they're doing the right thing, but actually what he appears to have taken away from the training as her boss is, if she's menopausal, I ought to just encourage her to carry the hand fan around the office. And she said that's not really the issue. And so I think there's going to be a learning curve, I think, with businesses, because some of this that we're suggesting people should put in place is going to backfire and go wrong in the first instance, I think, because I think some people will try hard and get it wrong before perhaps people learn from their mistakes and start getting it.
It's like when we're talking about introducing menopause policies, and actually people who were thinking about introducing them, the females were against that, and you think, wow, it's hard.
Yeah, it is tricky because menopause symptoms can relate to things that are to do with performance and capability. It's really tricky, isn't it? Because you don't want to be effectively saying, oh, I'm a helpless menopausal woman. You know, I've got no concentration, I've got no memory, I'm forgetful. That's not the image like an employee wants to present at work, and so there is that stigma essentially of almost talking about it.
And that's the argument I got in relation to menopause policy, where a lot of women were very much against the menopause policy being introduced and said, but if this policy is introduced, then everybody's going to assume that every woman of a certain age won't remember her own name, is going to sit near an open window, won't have a clue what they're doing.
Enough windows.
Absolutely. And you know, we will effectively all be tarred with the same brush. There's no chance we'll get promoted. There's no chance we'll be able to carry on with our careers if everybody's reading these policies and saying, well, clearly they're going to get to a stage where they're going to be entirely incapable instantly. So I think it's
why so many women leave the workforce, because they find it all too difficult, and don't want to be in that situation where, you know, they're tarnishing their own reputation, and they've been very successful and suddenly feel that they just can't keep up with that anymore. It's really sad. And I see a lot of it from that side of it when people are leaving, and it's not that they've not been wronged in the workplace per se, but they just feel it's not what they want to continue doing.
It seems like a unique situation in the sense that although there are a lot of similarities to disability, and say mental health disabilities and physical disabilities, it's different because every woman goes through it, and it's also different because from what you're saying, Laura, there are certain really specific things that are very often going to help but don't happen at the moment. So before we sort of go on to, well, what should an employer do about it, can I ask you a sort of more basic question about the medical side of it? If you were to sort of get hold of a woman who is going through the start of the symptoms of menopause, perimenopause, at whatever age that may be, in very broad terms, a combination of diet, mental health therapy and HRT, how effective is that going to be? I appreciate you're going to say how long is a piece of string, depends on it, but you know, is there scope for that making a really big difference to symptoms?
Yes, huge.
So if we take the examples of the two women that we had the descriptions of, Miss Rooney and Linsky, you know, we had a real definite description there of extremely serious symptoms, the sorts of things it's difficult to imagine somebody being able to continue to work actually with those symptoms. And imagine those two patients on a good range of therapies. Yeah. Could that get those two women to a point where they were able to work normally? Yeah.
Much, much better. I mean, maybe not back to full, 100% where they were before, but yeah, hugely. So I think people maybe don't seek the help, or there may be barriers from the medical profession. There are a lot of doctors who are scared of HRT.
Because of that trial.
That's still a massive, problem. Or they've been told by somebody, oh, it's not menopause. I've tested your hormones, they're normal. So then people don't realise, and I think, I can't remember which case it was, but one is saying, then they were referred for therapy, or they had antidepressant treatment. Yeah, but that might help one aspect, but not all of it. So if there are interventions that will make a huge difference, but it's getting people to access them and then getting them effectively given to them when they access them. And then there's the limitations of for most people, a 10-minute GP appointment. They might get some HRT thrown in and they might not. But the lifestyle stuff.
Forget it.
Yeah.
It's interesting that NICE, the National Institute for Clinical Health, a few months back, they were saying that instead of HRT, the first form of treatment should be cognitive behavioural therapy, which is a talking therapy, and I'm sure it has
we all went
value.
mad.
But it was really so patronising, as if essentially it's a hormonal deficiency, a massive drop in your estrogen levels, and the idea you can just go talk about it and that will solve everything. It was a massive backlash.
Yeah.
And they've now restored, haven't they?
Yeah.
HRT is the
It's our
first
first line.
form of treatment.
But they haven't licensed it. It's still not licensed, as it's the indication for it is hot flushes and menstrual irregularities. It's not all the brain fog, the, difficulty concentrating, the anxiety, the, bone
Is that
health.
because of the historic risk of, or the perception of a historic risk of breast cancer?
It's a problem across
Why
the
not?
whole. Yeah, I know. It's a problem across the whole of medicine. There's so many drugs that are licensed for certain things. We use for loads of others, but the licensing still doesn't. And it's a lot to do with pharmaceuticals as well, in terms of, proving, doing trials and all of they've got the data to. There's many things that come into it. And I hope that in time that will change as the array of symptoms that it is being pushed for. Everyone's, people who work in the menopause industry will still prescribe it hugely, but it doesn't stop a lot of people. But I think it makes some people still anxious, and makes patients think, oh, well, it's not menopause because my periods. But I'm still having a regular period. Can't be menopause. And a lot of people are still having very regular periods with horrendous perimenopause symptoms. Should have said that actually.
If you have had like breast cancer and you can't therefore take HRT, are there what other treatments are there?
So there are some people who've had breast cancer that can still take HRT, firstly. Second, but if we say most people can't, a lot of them can still have vaginal estrogen. And a lot of people don't know that. And so in terms of the sort of bladder and pelvic floor health we talked about, that can be addressed through that. But then it does come down to all the lifestyle work, and it's making sure that we are, if we look after stress management, sleep, nutrition, exercise, then things will be massively improved. And I always look at it as a sort of 4 or 5 piece jigsaw. HRT is one of those pieces, and the other 4 are those lifestyle components. So HRT, if you're still not looking after yourself, you're still eating badly, you're not exercising, your sleep's a disaster, and you're under a huge amount of stress from other things, you're still going to have really bad menopause symptoms. And so when we get when we're stressed and our cortisol levels go up, our stress hormone, that impacts our other hormone balance as well and makes our symptoms of perimenopause worse, as one example.
Just following on from the question then about the medical interventions, can I ask you about downside of those interventions and side effects?
Yeah.
And also, there's been a bit in the press recently about some leading doctors who are menopause experts going outside the guidelines, and whether or not that's a good thing. And that has given me the impression as a layperson that possibly hitting the optimal amount of medication is quite difficult, and maybe more difficult for some people if they're not able to keep going back and getting that repeat appointment. Appointments are difficult. So I'd love to hear your medical view on that, and then how that plays into the employment, the legal side.
So in terms of risks of HRT, so the most common risk that everyone will know about is there is an increased risk of breast cancer. And to put it into the basic terms, so if you look at women aged 50 to 59, we expect per 1,000 women in the population, 23 women will get breast cancer in the normal population. If you add HRT, if you give HRT to those women, those numbers go from 23 per 1,000 to 27 per 1,000. So we're seeing an extra 4 cases per 1,000 of breast cancer, which isn't huge. So 0.4% increase. What no one talks about is actually if you're obese, if you're very overweight, your risk of breast cancer is doubled.
And drinking alcohol.
Drinking alcohol is a bigger risk. Drinking more than 2 units a day. Our risk is decreased by exercise. So go on.
And you said there are other risks that are reduced.
Yes, and then we've got the reduction in cardiovascular risk and osteoporosis risk with the HRT. There were, in the Women's Health Initiative, the Million Women study in the early 2000s, there was a lot of emphasis placed on blood clot risk, and that is increased in only if you give HRT by mouth. which we really very rarely do now. Most HRT is given through the skin. The estrogen through the skin, that you can take progesterone by mouth, fine. And so the main risk really is breast cancer, which isn't a very big risk, and it's got to be taken in context of a personal history, and some people aren't happy with that risk at all. If you just give HRT, you give estrogen and progesterone, and the main thing you want is the estrogen to improve your symptoms, but you have to give progesterone to protect the lining of the womb against the estrogen, because if you just give estrogen, the lining of the womb gets thicker and thicker and thicker and can become cancerous. So women without a womb can just have estrogen because they don't need to protect that part of their anatomy, and their risk of breast cancer is lower on HRT than without. So there is almost an argument
without it.
Yeah. So there is almost a risk. There was almost an argument to say, well, actually, if you're high risk for breast cancer, if you've had a hysterectomy, you should be on HRT because it's going to reduce your risk. So, and side effect wise, most people, the pluses far outweigh the negatives, and the side effects you tend to be more when you start HRT. So things like I have some mood fluctuations, breast tenderness, skin breakouts, some irregular vaginal bleeding sometimes. Most of those settle in the first few months. So side effects generally aren't that huge.
Am I right in thinking that some people don't get on well with progesterone, and that for that reason you can end up needing to think again? I appreciate this maybe getting more granular than some people would like, but I'm thinking of that employer then who is dealing with an employee who's having to have maybe multiple appointments. They themselves are struggling to get a baseline because of the potential that their notes may well say that they're getting treatment for menopause, but they might not. And so that knowledge piece for the employer is tricky, but the management is tricky for the individual.
So there are different ways of giving progesterone. So often adjusting how it's given can be really helpful. There are some people who really don't get on with progesterone at all. I've got one patient who's had a hysterectomy because of that, which is quite extreme, but she has desperately needs HRT and is suicidal on progesterone. So, but that's probably one case I've come across in my entire career that's been that extreme. And as your point about the recent Panorama documentary, which probably not everyone in this room has watched, but essentially was looking at people being prescribed very high doses of HRT in one specific clinic, and it's tricky without knowing all the details. But what was glaringly for me missing from that documentary, the information I didn't know, was they didn't appear to be monitoring blood levels of the estradiol levels, the estrogen levels in these women. So they're saying, oh, well, your symptoms aren't better on HRT. You just must not be absorbing enough estrogen. Have some more. And these women were being given at least double, if not 3 or 4 times the upper limit of the normal dose. That's one of those times we do use blood tests to sort of monitor, are people actually absorbing, because we get most of our estrogen through the skin, and there's a lot of variability into how that is absorbed. And it wasn't clear from that documentary whether they were being tested. And ironically, one of the women on there, she was saying, oh, my symptoms were worse, so they gave me more. And actually, if you give people too much estrogen, it does make their symptoms worse. So it was unclear to me as to whether that was what was happening or they genuinely weren't having enough. But there are health risks with having too much estrogen without enough progesterone. And there was a lady on the documentary who'd had a recurrence of cancer affecting the lining of her womb, which spread to other parts of her body. It's not normal practice, and the only thing I would say is there were only 4 people on that documentary out of a huge number in the clinic.
They treated 45,000 in the Newsom clinic. So
we don't know the full, but it was sad. I found it really sad because I thought it's made a lot of people now anxious again about taking HRT, and I have very few women, if any, who are taking over the normal kind of upper limit recommended dose. And if you do go above that, there are certain things you should be sort of doing to make sure things are safe alongside that. But yeah, it was a bit of a step backwards.
Yeah, it's a shame. I think it's a shame because that doctor's been a massive champion, and actually she often does webinars and things with Davina McCall. So I think she's been involved with Davina McCall as well as Naomi Wood.
Yeah.
This particular doctor's been involved, and actually she's been on tour as well, all around the country.
She's been everywhere.
She's been everywhere. I think giving in the simple 18 cities, and so I think she's getting her confidence back. But I think she was really knocked by that panorama program that seemed to be setting out with a bit of an agenda to try and
Find the bad cases.
to find the bad cases. I think there's
I don't know what that agenda was. I mean,
Tell the story.
yeah, I guess so. And I'm there going, oh,
Anti-Davina, maybe.
yes, yeah. Does that answer your question?
yeah.
Sorry, I can witter on for hours.
Oh yeah.
Can I ask, were there cases you found, some of the only reported cases? Or
I mean, these are the only cases I've found. I'm sure there are loads more coming through in the pipeline, but obviously there's just the one appellate case, and so.
why do you think why there are so few cases that have been dealt with by the tribunal?
This is complete guess. This is my made it up guess. But I think because it's so underreported and because so many people haven't been told about it. So I think it's the knock-on from the Davina effect. So I think, Davina McCall said, hey, everyone, might this be a thing? And then that's starting to filter through. And of course, it takes longer to hit the courts. And then we know how much delay there is in the court system. So it takes longer to get through to reported. There'll be some who've been through the tribunal system who won't yet have got through to the EAT. So I think gradually, and the word from some of the solicitors that I've been talking to is they're starting to see these cases come through.
Yeah.
So Liz in the audience was Rooney.
I did some of Rooney. That's still waiting for
really?
the final tribunal.
Yes, I've heard it's a 16-day case. I
It
understand.
was a 16-day case,
Initial.
but she's still, I think her case has been ongoing since 2018.
That's right.
I've had a case that settled where the issue was menopause, and it was just so completely mishandled by the organisation that it ended up being mediated and settled, and perhaps that's happening too, that cases are just really bad and the respondents aren't fighting them. I'm not saying that overall that's what's happening, but this probably.
And I had a solicitor, he said to me that they'd had a menopause case where the client had come to them and said, well, this is clearly ridiculous because this woman cannot be disabled, she's just got the menopause. And they'd had to sort of backtrack and say, actually, and they had a whole conversation. The client had sort of huffed and puffed and said, "Oh, it's ridiculous." But actually, exactly what you're saying, that the solicitor was saying, I think this is something that needs to be settled, and the client was starting to try and come round to that idea. But maybe either they're settling or.
Yeah, I think it's going to change those in the next 10 years because look at the people going through perimenopause and menopause now. Mostly the generation whose parents or mothers didn't talk about it at all. It was something that didn't happen. The majority of people, and there's so much talk now. So there's a lot of women in their sort of late 20s and early 30s are like, right, I'm preparing now for my perimenopause, and they're like, they will be championing this.
And that will help on the medical side. And if you're going to your doctor and saying, I want you to
look at all these symptoms, and I took 15 of them.
But just a general comment, really, just female. I think there is, let's face it, with other female health issues, it's a bit notoriously difficult. You keep going back to doctors and saying, got this, and this. But the joined up approach, we know, is difficult.
It's also really scary that we've got to this stage in 2024 and lots of the research hasn't actually been done. And you're saying the research was sort of 15 years skewed because of one study. And you think, well, we are just over half the population we will all go through menopause. It's very odd that the research hasn't been done. So perhaps if that research starts to get done, that will also filter through.
Do you have a sense, Laura, of how, if you've got 1,000 women in front of you, how many of them will have symptoms that will affect them at work during their perimenopause? Sorry,
I mean,
we're on the spot.
I say got some statistics.
Yeah, go on. I think I'd say around half.
2/3 of working, this
There we
is from the EHRC guidance, 2/3 of working women aged 40 to 60 with experience of menopause symptoms say they've had a mostly negative impact at work. 79% say they've been less able to concentrate. 68% say they have been more stressed. Nearly half, 49%, said they felt less patient, and 46% said they physically were less able to carry out work tasks. And 1 in 10 women left because of menopause symptoms.
Yeah, it's very high.
And in certain occupations where women make up the majority, I think healthcare and social care work, it's going to have such a massive impact if everybody's leaving, or lots of people are really substantially affected, adversely affected. So it's got to be, it's got to be taken much more seriously, definitely. One more question.
Yesterday, we're going to have menopause action plan.
Yeah.
Shortly. So just thinking about what those should look like, could look like.
Yes, I think as the Labour government committed to introducing those for businesses more than 250 employees, and what those will be. I presume it's the same sorts of matters we've been talking about: the menopause policies, the champions, the training, the support, review of policies, disciplinary policies, performance policies, attendance, sickness policies. Those are all sorts of things.
And I can't wait for that case where somebody does something with the fan when it's still. And then there's a missing. We have to defend it on the basis they were pushed to it.
This is something arising from menopause. They shoved it where the sun don't shine, and the justification is that they deserved it.
The case that I had that settled was a case where the individual had really not got on very well with a lot of people, and it was precisely that sort of situation where she was treated badly because of the symptoms, and then that made her more impatient with everybody, and then she was getting into sort of arguments and fights with people. So I think it gets vicious cycle. It gets worse and worse and worse and worse until the person is either sacked or leaving.
What do you do with probationers, especially you've got day one rights coming up soon to sue for unfair mismanagement? You could always sue for discrimination before, but what do you do with a probationer who's just started, and then they're hopeless, they're just terrible at their job, and then they're saying, well, it's menopause.
You can't compare it.
What do you do? You don't have an established good record, as you did in the Linsky direct line sales case. You've got nothing to compare it. What do you say when they fail their probation and they say, yes, but this is section 15 menopause?
There, I think it's easier to say you must go. Well, there it's easier to say occupational health, because that's what you're being told as an employer. You can say, well, we have to identify whether that's right or not. The way to do that is by.
How do you separate out whether they're just a bad employee?
Really good and then actually, you sort of end up in more or less the same. So I mean, let's say they go to occupational health, and occupational health says, congratulations, you are perimenopausal. It's going to be 10 years, so fingers crossed. As an employer, if someone's only been with you for a couple of months, you're probably not going to say, well, okay, we'll sort of. I mean, obviously you would need to put in place, such adjustments as you could. But I think most employers are not going to want to kind of pull out all the stops for someone that's only been there.
And then you have to line justification, and then the issue is, what sort of evidence do you need to prove? Is it going to be like the all reasonably practical steps to avoid discrimination? Is it going to be actually something that's actually very, very hard to prove, that technically that defence is there, but how would you actually?
Especially if, in fact, as a matter of fact, the medical treatments are patchy in different parts of the country, and you can't necessarily rely on GP to give you the right treatment, then can the employer say, well, how long?
I think that HRT and so on, those things can be very, very effective. The question is, can they access it? Are they getting the right dose?
Or are they too scared to access it? Or,
We might end up in a situation where, instead of people avoiding employing the women of childbearing
I was gonna
age,
say
they're going to
exactly that.
avoiding the women of menopause
Yes.
age, and we're going to get a complete flip.
I'll take the pregnant women, it's fine. They're only got work for 9 months.
Sad note on me.
Cheerful note.
And on that sad note. Thank you so much. I think that's been really interesting, and it's been great to have your input as well. I think we should give them a round of applause. conversation doesn't need to end here. So I'm really hoping you're going to come through with us and enjoy some lovely drinks and food and